all of you. It's very impressive to see people joining from all parts of the country and the world, maybe. I'm going to tell you a little bit about my story, and then I'll share with you maybe some of the projects I'm working on. Overall, I think I'm a little bit of an untraditional pre-med and also an untraditional doctor. And I wanted to share my story with you to just give you a glimpse of the sort of possibilities medicine offers, especially for those of you who don't come from the traditional path. So I'm a little untraditional because, first of all, I grew up in Europe. I'm French, and I was in France until I finished high school, and then applied for undergraduate colleges in the US because my parents were moving to the US, and got into Cornell, which was very, very lucky, given that I hadn't really had an American training in high school and didn't really know how to apply to American colleges. And really, Cornell was a transformative experience for me because in France, basically, you have to make your career choice right after high school. And if you want to become a doctor, you just go to medical school right away. So what I really loved about the college experience in America was that you could really pick and choose what you loved in terms of academic experience and academic focus. And you could really spend 4 years to really discover yourself and really make sure that you were making the right choices for the future. So my first year, coming from France, I was kind of following the traditional pre-med pathway because that's what I wanted to do. And I was taking a lot of science classes. And in my second year, I started noticing that I really want to explore things like the humanities, and I really like more hard sciences. So I decided to take more classes in chemistry and also in philosophy, and I really found my home in those maybe more rational disciplines, and really enjoyed especially the philosophy major. And I think it's really important that, you as pre-med also give yourself the room to discover yourself and find your passions in college, and not really just focus on being the perfect pre-med applicant, because you're only, 18 to 22 once in your life. And those years are really years where you can explore and really discover yourself. And also, I really have found overall that keeping an open mind has been a very important part of who I still am, because it allows me to get a different perspective on my field and really bring innovations in my field. And I'll show you a few things that I'm working on in a bit. I also want to point out that I do have a parent who's a physician, and I think that especially in my generation, I don't know as much in the younger generation, that was an important factor in me already knowing about medicine. When I was in college, my mom is a physician, she's a surgeon, and she pretty much always wanted her daughter to be a doctor and probably a surgeon as well. And I had a little bit of, pressure from the family, but at the same time, I really took college as the opportunity for me to really examine that life choice and make sure that that was really what I wanted to do. And up until the end of undergrad, I was really contemplating, for instance, a PhD in philosophy. That is important because I ended up going to med school, and shortly after college, I took 1 year off to go back to Europe, and I did a degree at the London School of Economics in policy, because I wanted to see whether or not that was maybe a good compromise between medicine and philosophy. It was a really great year, but at the same time, I knew I had to make a decision at some point as to which career pathway I had to make, and then ended up deciding to go to McGill University in Montreal. And the reason I made that choice, and I think that's important for you guys to keep in mind, is that I knew that I wouldn't have to pay much tuition, because as a French citizen at the time, there was a partnership between France and Quebec, and I was going to end up paying, less than $5,000 a year for tuition for med school. And for me, that was very important because I didn't know yet what I was going to do after medical school. I thought maybe I'd be doing something in policy, maybe something in global health. And I just wanted to make sure I wouldn't have the burden of debt when I was making those choices. So I ended up going to McGill University for medical school, which was a really good experience also because it allowed me to learn about the Canadian healthcare system. And then actually, I went back to philosophy for 1 year after medical school because, and I'll answer some of the questions in the chat in a little bit. I ended up deciding to go to Cambridge for 1 year before residency to study history and philosophy of medicine. Because for me, medical school was very, very hard. Not so much, from a, intellectual aspect. I mean, it's not very hard. You just have to memorize a lot of things and build up your endurance and learn how to take care of patients. That wasn't really difficult. What was difficult for me was that you had to absorb this huge amount of information, and you didn't really have the time to really know where it was coming from, what was the research that was underlying it, and for me, it really made me question a little bit the basis of medicine, and I really needed to kind of understand the basis of knowledge in medicine. So that's a field in philosophy called epistemology, which some of you may know as a term, and so I really needed 1 year to kind of take a step back and really kind of examine how do we get to know things in medicine. The first day in medical school, one of our professors told us that basically 50% of what we'd learn during the next 4 years would be false by the time we graduate. And to me, that was really a shocking fact. I mean, I really was not very comfortable with the fact that, what I'm spending a lot of time memorizing would be wrong in a few years, and I don't even know where that knowledge comes from. So I took a year to go to Cambridge, which was amazing and incredible, but definitely something that, nobody was recommending at the time. I wanted to go into a very competitive specialty, ENT, and everyone was like, this is very risky, don't do it, just go straight into residency. I had the scores, I had the publications, but that was just, an internal calling, and I had to kind of follow it. And I'm so happy I did it because that year really, first of all, gave me a little bit of space after medical school because you're really exhausted after those 4 years. It helped me also connect with people who are not in medicine and really get a different perspective on life. But also, Cambridge was amazing because you live in a college and you make some really strong friendships very quickly. And also, I got to study what I wanted to study, which was the basis of knowledge in medicine, and I made it more specific. I made it the basis of knowledge within surgery and ENT, and that's something that I got a very good grade on. I was very proud of, and I also want to work on as a publication and potentially a book at some point. So that's again another untraditional element of my pathway, and then actually this served me well because when I went on interviews for residency, I think that was something that made me stand out, and it made me stand out especially at Stanford, where the department chair was someone of who was a little bit more of a Renaissance man and kind of liked the idea of someone who would be, looking at the big picture and not just a cookie cutter applicant. And I guess that's a general theme in my life that, I can't help it. I'm just myself. I can't follow guidelines for being the perfect applicant. I just have to be myself. But overall, it has served me well. Philosophy has been a good major, for instance, to get into medical school. It has been also a really good interest to get into a very competitive residency. So this is just for those of you who don't feel like quite the rest. You don't have to try to fit in. You can be yourself, and those unique qualities will really make you attractive as an applicant, but also as a physician, because patients will connect with you, they'll see that you're authentic, and individuals tend to be, or patients tend to be attracted to authentic folks. So just, try to be honest with yourself, and just, follow your passion I don't think is a good advice, because you need to be realistic. But, to some extent, follow your heart, but in a pragmatic way. And all of this to say, so it's interesting because I never thought that philosophy and sort of my background would lead me to a surgical subspecialty. And I never thought that it would also make me into an innovator and an inventor. But I think that the quality that philosophy gives you, which are to, learn to step back and look at the big picture, allow you to also be very creative in some ways later on in your life and your profession. So I wanted to just take a second to show you some of the things I work on. So to give you some background, I'm a laryngologist. I think you had Dr. Stinnett talk a few weeks back. Dr. Stinnett is also a laryngologist. We take care of the voice box, of the airway, and of swallowing. And so I'm going to show you a few projects within my field. So they're usually either voice, swallowing, or airway related. So I'll try to share some of the slides here. So for instance, this is a project we did with some medical students at Cornell. We created this 3D printed larynx. This allows us to basically teach a procedure that's usually done in the clinic, and it's very hard to teach fellows and residents how to do it. It's basically the injection of a filler on the side of the vocal cord for patients who have a vocal cord that's paralyzed. And interestingly, it's really gratifying, for instance, to make an object. So this came also a little bit from understanding my own experience as a trainee, and seeing that, it was really hard for me to learn how to do this procedure because, the patient is awake, so it's really hard to feel comfortable doing a procedure on an awake patient. So it was a really long process to make a 3D printed model of a larynx that would be usable for a simulation of a procedure. This is just a framework of the larynx, which was not so complicated to make, but then we had to make the soft tissue within the larynx, which required a lot of computer design. And then eventually we got to this very workable model with silicone and a silicone inset within the 3D printed frame, which we can actually use to inject air and really give the experience of injecting a vocal cord, which again is very difficult to do. Otherwise, you can always use animal model, like animal larynxes, but those are only one-time use, and they can be wasteful. So that's one project, just to give you an idea. Another project I've been working on has been a little bit of also more like an entrepreneurial venture. So this is called Myophonics. So it's turning into a startup. It's a silent speech device. And I usually start telling the story of my grandfather, who was a writer and was also a smoker and lost his voice to laryngeal cancer. So this story was really important in me choosing ENT as a field of specialty. And unfortunately, for patients who have laryngeal cancer, the options for voice restorations are extremely limited. And so you may have heard about the electrolarynx, which basically is a device that vibrates and allows to use the vibration of this external device to create an artificial voice, but it's really a terrible voice quality, and it's very stigmatizing to patients. And there are many other patients who lose their voice, either because they have a tracheostomy, or because they're intubated, or they had a stroke. So we basically created a device that's a wearable device. You hold it to your face, just like a phone, and it picks up on the electric activity of the muscles of articulation and translates that into speech using a machine learning model. So that's been another project I've been working on. And then most recently, in the context of COVID, this was something that we recently published, and I'm just going to show you. This is a very early prototype, but basically I collaborated with space engineers at Cornell who had knowledge in simulation of fluids to create this helmet that would allow to capture aerosols generated during procedures in the office. That was a big concern for my field in ENT because we treat a lot of patients who have, throat pain and or nasal congestion, and we were very concerned about the aerosol and the exposures within our specialty. And it's also a very common concern even today within the dental office. So we created this simulated device, which eliminates basically all concerning aerosols during procedures. And those are just to give you a little glimpse of the type of things I work on. And I also do a lot of work around swallowing, which is a very, it doesn't sound very sexy, but it's actually a really interesting part of my field, because when you think about it, eating is such an important part of being human and having a social time. I think that, we can appreciate that in the time of COVID, because being socially distanced, we really miss those meals we had with family and friends. And it's actually an amazing field for innovation because there isn't much that's available. And this interest in swallowing has brought me actually to Japan. And I can show you some of the work from there. Just give me 1 second. So Japan has been super innovative when it comes to swallowing issues. So some of the things they do is, for instance, create new types of textures for foods to make sure that older folks who had stroke, for instance, can still eat a meal that looks appealing and is safe to swallow. They have all types of devices they come up with to restore swallowing function and train, for instance, the tongue muscles. So this has inspired me to work on things like a swallowing device. So we're trying to rehabilitate right now swallowing using an external wearable device that basically gives haptic feedback whenever you're doing the correct swallowing movement. And then another thing I work on is creating a vocal screen for patients who are at risk of food going down the wrong pipe. So this is an animal model. We were recording voices from this larynx with, as you can see, some liquid on the vocal fold or no liquids on the vocal fold. And we're capturing the voice and the sounds produced and basically using that as a way to see whether we can use machine learning to distinguish patients who have food on their vocal cords and are at risk of food going down the wrong pipe, and those who are not at risk. So those are just some of the glimpses of the things I do. So again, I think what I want you to capture from me is that maybe not for everyone, but if you feel like you're a little different and you still love medicine, don't be shy to bring your unique features and traits to the field. And actually, this will probably augment your specialty, because you're going to bring a new perspective, and this new perspective may make you into an innovator. And it's actually really, really fun to be that type of person, because people just don't know what to expect from you. So they usually give you free rein. And I've really enjoyed being, a woman innovator in my surgical field. It's very unique. I think it gives me a lot of freedom, and it also gives me a huge range of creative options for what I can do for my patients. And with that, I'm gonna leave it to people, to the team to ask me questions.
Great, thank you so much. This was super interesting to see. I think there's some biomedical engineering majors, so they all liked seeing all, what you're working on. So pertaining to the research, someone asked, how often do you do research in your current field? Is that like a half and half thing? Do you get to pick? If you could kind of talk about that.
Sure, so that's a very good question. So as a surgeon, the economic pressure usually is for you to see as many patients as possible and operate as much as possible because you generate a lot of money for your hospital. So in general, the surgeon scientist profile has been falling out of favor because it's not thought to be, high financial reward for the institution. But for me, I knew right away that that's something that I wanted to do. So one issue is negotiating your contract, your first contract when you're out of residency. And I think it's very, very important at that point to request what you want, because if you don't do it at that point, then you're unlikely to get it later on. So from the get-go, I knew that I wanted to split my time between seeing patients and doing research work. So that's something that I requested from the beginning. I requested 40% of my time to be assigned to research. This did not come very easily, but I said that that was the condition for me to take the job. And I was lucky that the specific fellowship that I did was in high demand. So I had a little bit more of a say in what I could get. And then what I did in my first year is right away work on grants, because once you get a grant, then you secure your time. And people can't say anything. Once you have a grant, it's very prestigious. And you basically have automatically protected time.
Great, thank you so much. It's good to know that it's still feasible to do research for those the people that would like to do that. And there was also questions asking how you go about finding patients. Is it easy to find the type of patients that you work with, or is that are your projects more like years long as compared to like months?
Yeah, so it depends on the projects. If you're talking about patients for research recruitment. Yeah, so it depends. So for instance, the patients who have no voice box because they lost it to cancer, they tend to be not so, there are not so many of them, but it's a fairly tight community. So, so if you want to reach out to them, you just need to find the association within your city or your state. And usually patient associations are very good at garnering interest. And it's a good way to, for instance, recruit patients for your projects. It's true that some projects will, take a few months. Some projects will span several years. And that's the nice thing about research. You need to be working on a few things at a time. And it just adds a little bit more diversity to your day-to-day.
Great, thank you so much for answering that. We had a question earlier, if you could just touch on this again, how you get involved with research in the first place. Is it something that you do with connections, or you have to apply for them just because you have the idea? If you can touch on that a little bit.
Sure, so so first of all, I wanted to be in academics. That was very important to me because it wasn't really appealing to me to be a businesswoman and to make my practice into a way of generating revenue. I always wanted to deal with ideas, and I think that's just my intellectual curiosity at baseline. Also the residency that I did at Stanford was very academic, and our chairman had very high expectations of the type of person we should become. And he is a very inspiring individual, very smart, and he dabbles in science, in the humanities, and very broad mind. So I'm, coming with that background, I knew that I wanted to incorporate research in my future career. And also, you know, I did take a little bit of a risk by deciding that I was going to apply to grants and see where this would lead me. And I was very surprised to see that grants were actually quite achievable. Whereas, you know, some people may never apply because they're too scared of getting a rejection. I guess I expected rejections and I got some, but I also got some positive answers, and you just need that one positive grant to, you know, fund your project, and that's it. Does that answer the question?
Yeah, I think so. Okay, so we have another question. I think that was really interesting. It was about the 3D printed vocal cord. Do you think that this technology, this utilization could allow us to implant it instead of using external devices in the future, or an internal implantation or something like that?
Yeah, that's a very good question. It's a complex issue. So the larynx is not just a passive structure, it's innervated. The vocal cords need to basically move away and make room for air to come into the airway and then come together when you swallow and when you use your voice. So the problem is not so much creating the structure, the problem is more the innervation, and also making sure that the innervation works you know, appropriately and is coordinated with breathing, because, you know, that's the one surgical emergency we have in laryngology. It's the airway. When everyone else fails, then the laryngologist comes into the picture and saves the patient. So airway is really kind of the limiting factor right now. There are some regenerative medicine labs. There is a really good one at Mayo Clinic in Arizona. There is one also in Kyoto, Japan. But right now, we're not quite there yet. There's been a couple of attempts for transplant of the larynx, but there is actually an interesting ethical issue in that you don't really need a larynx to live. In fact, a lot of our patients lose their larynx to cancer, and so you can't really justify putting someone on immunosuppressive medicine for the transplant of a larynx. So the only patients who are really candidate from an ethical standpoint are patients who already have a transplanted organ. So UC Davis, where actually I did my fellowship, had the one successful laryngeal transplant done, and I met that patient. And unfortunately, even though she successfully had a transplanted larynx and can use her own voice rather than electrolarynx or another form of rehabilitation, her vocal cords are not moving, so she still has a tracheostomy. So that really remains the puzzle right now in laryngology. Re-innervating the vocal cords is a real issue. There is some interesting research coming out of France on how to do that, but it's still it's a very complex surgery and it doesn't work all the time.
Awesome. Thank you so much for talking to us about that. There were several people wondering how often you work with children. So is that something that you need to be further specialized in, or can you do that with the training that you received?
Yeah, so the nice thing about surgical specialties in general is that they allow you to treat all age groups. Then you kind of make a decision. You can see all age groups if you want to, or if you prefer, you can focus on a specific age group for your work. In academia, we tend to be more specialized because we see a lot more complexity. So we tend to see more patients of one kind. So for instance, if you're a laryngologist, you can still see pediatric patients, but most of us will decide to just focus on the adult patients. Throughout my training, my 5 years residency, I treated a lot of pediatric patients as well. And I did consider, for instance, a career in pediatric ENT and a focus on the pediatric airway. But then I decided I really wanted to focus more on adults. So that's why I did an adult laryngology fellowship. But let's say, you know, I get bored in a few years and I really want to go back to a pediatric population, then I can, you know, I mean, that would be a little crazy, but I could do a fellowship in pediatric ENT or decide to move practice and just focus on the pediatric population. probably after observing a colleague for a month or so.
Awesome. Thank you for that response. There's also a question asking how, if you work with neurosurgeons or neurologists to try to solve the problem of reinnervating the larynx, and I guess to that effect, how often you work with other specialties other than your own?
Yeah, absolutely. So the larynx is, you know, it is a nice organ to lead to collaboration. So first of all, we collaborate with a lot of the other airway specialists. So that includes thoracic surgeons and anesthesiologists. We do work also with the neurosurgeons, but typically not in combined cases, because typically what happens is that I will see patients who underwent neurosurgical intervention, and they either have trouble swallowing now, or one of their vocal cord is not moving, and I have to find a way to restore function in those patients. I do work with neurologists because I'm, again, really interested in swallowing, and actually the #1 cause of death in Parkinson's and stroke is food going down the wrong pipe and causing pneumonia. So again, that's why I find swallowing really fascinating, because it can actually have a huge public health impact to improve swallowing function in individuals. But in terms of collaborating with neurosurgeons and neurologists for restoration of vocal fold movement, that's not something that we actively do, because we're talking about peripheral nerves, and for peripheral nerves, we as surgeons have the expertise to think about how to restore the function of peripheral nerves. You don't really need a neurologist or a neurosurgeon for that.
Great, thank you for that explanation. We also had a lot of people ask if you could describe what a typical day looks like for you, if there is really a typical day for you.
Sure. I basically split my week between research time and seeing patients and operating. So for instance, today, this morning I operated. I had 2 patients, and I just came out of the operating room to make it to this meeting. Now I'm talking to you, and this afternoon I'm going to mentor a medical student who just applied for ENT residency and wants to work on his rank list. And then after that, I'm going to be finishing up a paper that I want to submit before my maternity leave in 10 days. So that's, you know, that's one typical day. Another typical day would be seeing patients all day in clinic and basically doing a lot of procedures in clinic. So my field in laryngology allows me to do a lot of the work that we used to do only in the operating room in the office. Then that means that I can do biopsies inside the throat, for instance, in the office. I can do stretching procedures of the airway or the swallow pipe, the esophagus in the office. I can treat papillomas. I can do injection of the vocal folds. So there are a lot of things that I can do in the office, and allows me to also save a little bit of time, because going to the operating room is not always the most efficient way to do procedures.
Absolutely. So that's great. There also was a question about how COVID has changed or impacted, you know, the way you practice or how the office looks right now.
Yeah, so it was really fascinating in the field of ENT, because initially the first doctor who actually died from COVID was an ENT doctor in Wuhan. And from the beginning, there were a lot of reports coming out of China and Italy that, you know, ENT doctors were dying and were heavily exposed to the virus. So we thought initially that our specialty would be wiped out by the virus. And we were very, very concerned about seeing patients, because, you know, a lot of our patients will come with cold symptoms, sore throat, vague symptoms that involve the nose and the throat. And those are also the symptoms of COVID. Chronic cough is a common condition that we deal with. So initially there was very little knowledge, and actually we put out a paper, and I was one of the authors on, how to protect ENT doctors during laryngoscopy, which is an office procedure to look at the vocal cords. And at the time, we thought that all patients had to be seen in negative pressure rooms and that we would have to wear, PPE even in the negative pressure room. And basically, over time, we noticed that the rates of infections were not that high among ENT doctors. And actually, another paper I worked on during the pandemic was to measure the number of aerosol generated during laryngoscopy. And we found that those were not that increased compared to normal speech and normal breathing. So as a result of that, we still are wearing full PPE when we're seeing patients to protect ourselves and to protect patients. But really, it's mostly because when they talk and when we talk, we produce aerosols. It's not so much our procedure themselves that are aerosol generating. So right now we're back to a normal practice. The only thing we're doing that's a little different is the PPE and the fact that we're trying to space out patients in the room so that there is enough time that elapses that all the aerosols are evacuated from the room.
Thank you for sharing that. And kind of going off of that COVID question, have you noticed or do you anticipate any like long lasting effects of COVID in the airway and kind of with the body's parts that you deal with? Or have you seen any? Do you expect it?
Yeah, definitely. So ENT has been actually a little bit at the forefront of a lot of things happening with COVID. One, we know the nasopharynx. So we've taught, for instance, other physicians how to really test for COVID and how to get to the nasopharynx. So just so you know, the floor of the nose is perpendicular. It's not going up. So you don't want to point this way when you're doing a swab, but you want to go this way. So that's one thing. Other things we noticed pretty early on is that one of the first signs of COVID is anosmia or hyposmia, which is the loss of sense of smell. So we've been very active in collecting data on this and also finding ways to screen early for risk of COVID based on that symptom. There are also other cranial nerves that may be involved by the infection. And currently there are some thoughts that there might be an increase in sudden sensory neural hearing loss, which is hearing loss on usually in one ear that's sudden. So that's something that colleagues are studying right now to see whether or not that might be caused by the virus. Within laryngology, there have been a few things. One is that some patients had to be intubated for a long time, and intubation can lead to scarring of the vocal folds or the area below the vocal folds called the subglottis. So one thing that we were expecting to see was a huge rise in the number of patients with trouble breathing after extubation. And that's been somewhat true, but not as bad as we initially thought it was going to be. We are also seeing patients who are reporting some vague throat symptoms or difficulty swallowing. And that's still something that we're examining. We're collecting data on it, but we don't have any specific patterns that we're noticing.
Great. Yeah, that's good to know. Kind of what you have seen as an expert in the field. And you mentioned that the loss of smell was one of the first symptoms that people were noticing. And there was a couple of questions asking why that even happens and why COVID brings about those changes.
Yeah, so that's a good question. We're still learning a lot about this virus and its effects. And one of the things that we've noticed is that it tends to lead to basically some small clots being formed and causing some neurological symptoms as a result. With the sense of smell, so part of the issue with cranial nerve number one, the one that's the olfactory nerve, is that it's a very simple and kind of primitive nerve that has basically some small branches that are very close to the nasal mucosa, and it's connected to the brain pretty much right away. So it's a very, very simple nerve, and it is thought that part of the issue is the inflammation in the mucosa of the nose that's leading to some damage to the branches that are connected to the brain. And it is also thought that, part of the issue is that there is also an impact of COVID on brain function, and that could also be contributing to the hyposmia or the loss of sense of smell.
Great, thank you so much for explaining that, because I know Lana and I both wanted to know that too. Still on the topic of COVID, given that there's a global health disparity that's come to light during the pandemic, and there's definitely a need for more ENT and training in this field. Is it a consideration, or do you, I guess, what's the word I'm looking for? Do you think that it's a good idea for individuals looking to go into ENT to be more involved in global health initiatives, because there's a lot of disparities in inequality?
Yeah, absolutely. So when I was in residency, I spent 1 month in Zimbabwe with a team of otolaryngologists. So in the whole country of Zimbabwe, which has 15 million people, there are only 11 ENTs, or at the time when I was there, it was only 11. So, and most of them were in the big city because they were seeing mostly private patients and making money with that and not really serving the general population. So definitely there is a huge need for specialists and subspecialists across the world. Although I do think that we also have to think in a more innovative way, that maybe, having physician on site may not always be the best answer. Right now with telehealth, we're learning, some potentials that we were not as aware of in the past, including the fact that you can do a lot of diagnosis away from the patient, but we're also finding that we can integrate a lot of the telehealth visit with machine learning, and there are certain things that we can capture at a distance that can help us get to a diagnosis. One of the major issues within ENTs that our exams involve looking inside cavities. So looking inside the nose with a camera, looking inside the throat with a camera. And that's not something that can be easily performed at a distance. So for instance, I work with a team of engineers at Cornell Ithaca to try to resolve this and find a way to do distant exams that would not be too invasive or too difficult for the patients to perform. But definitely, generally when people think about global health, they think about general medicine, general pediatrics, emergency medicine, but there's also a huge need for specialists. My colleague who is just next door is a spine surgeon, and he created a whole neurosurgical program in Tanzania because there was no neurosurgical care in this whole country. So that was very transformative, because head trauma, for instance, is very common in developing countries, and there just was no advanced care.
Great, that was very informative, and it's good to think about the telehealth aspect, because that's something that we all have to utilize now. So thank you for that. Again, another COVID question, there's so many. So since the virus spread so quickly, is there a reason that the test has to go so far or so deep into the nasal cavity? And also coming with that is, do you think that the self-administered tests are less accurate than the tests done by health professionals?
Yeah, so I don't know the most up-to-date data, but at least what I know is that from the very beginning, samples were collected from different parts of the nose and the nasopharynx, as well as the oral cavity and oropharynx. And most reliable samples were coming from the nasopharynx. So that is why even today within our hospital system, if we want to test patients for a risk of COVID, we'll do the nasopharyngeal PCR swab. That seems to be the most reliable, although, you know, rapid testing is not very reliable, and a lot of the tests that are based on saliva right now do not seem to compare exactly to the nasopharyngeal swabs. But that might change, and I really think that, you know, we need to work on further innovation, and there is room for making things better. And I know we're all tired of COVID, and we don't want to think about it as much as we were obsessed with it at the beginning, but there's still a lot of room for innovation.
Definitely agree. So hopefully we can do that faster and better and more effective in the future. Kind of stepping away from COVID, what would you say are your most commonly performed procedures?
So procedures in the clinic or in the operating room?
Let's say both.
Both, okay. So a very common procedure in the clinic is, first of all, doing diagnostic tests to look at the vocal fold and diagnose patients with pathologies. Right now, that's something that we're trying to automate with machine learning to see if we can do that even faster. I do a lot of medialization procedures. So a lot of my patients will come with a vocal cord that's paralyzed. And basically, I use different types of fillers to augment their vocal cord and allow them to have a stronger voice and to have a better airway protection when they swallow. Another very common procedure that I perform is using a laser called a KTP laser to remove lesions on the vocal cords, including vocal fold polyps, which we see in New York a lot more commonly when the Broadway shows are going, or, you know, when people are not all at home. Another common procedure is looking in the esophagus in the clinic. So that's a nice thing I can do as an ENT, that I can actually use a camera that goes through the nose into the esophagus. So as you may know, esophageal cancer is one of the few rising cancers in society. So that's a good way to screen for Barrett's esophagus or finding early lesions that can lead to cancer. I also perform manometry, which allows me to diagnose dysmotility problems in the esophagus and also related to throat weakness. So those are some of the procedures I do in the clinic. In the operating room, I do a variety of procedures. So for patients who have a vocal cord that's permanently paralyzed, you can place an implant in their voice box. And that's a very cool procedure because the patient is not under general anesthesia, they're under sedation. So basically you fine tune their instruments. So you place the implant in a little window that's placed right next to the vocal cord to push it over closer to the other one. And you have the patient voice throughout the surgery because they're awake. And once you're really fine tuned and you're happy with how their voice is sounding, and they're happy with their voice, and you're happy also with how the vocal cords are looking because they have a camera through their nose to look inside their throat, then you can secure the implant and close the neck. We also do surgical removal of cancers on the vocal cords, but we tend to focus more on early cancers. Some of my colleagues combine their work with also cancer surgery for the voice box, so they'll remove the voice box and do neck dissections. The nice thing about laryngology is you can decide whether that's something you want to do or if you don't want to do it. So for me, because I'm also a researcher, I don't want to spend too much time in the operating room. So those cases tend to be on the longer side. They tend to be roughly 6 hours, and then the patient stays in the hospital for a long time. So it's up to you if you want to do that as well. We also help spine surgeons, for instance, accessing the spine and placing hardware on the spine because they usually go from the front and they pull the larynx away from the spine, the cervical spine. That can cause injury. So usually we help them with the approach to make sure that they're not injuring the nerves or the structure of the voice box. That's just to give you a little bit of an idea.
Thank you. Could you clarify the name of the procedure you were describing with the fine tuning?
Yeah, sure. It's called a medialization tharoplasty.
Okay, thank you. Someone was asking.
Yeah.
And a more like, as a physician kind of question, are there any times when you are in the clinic practicing or in research that you feel like you're in the kind of a repetitive manner state, just kind of doing the same things over and over again, and if that ever gets like exhausting or just kind of taxing, and if there's any way to combat that?
Yeah, that's a good question. That was something that I was a little worried about, becoming a subspecialist, that I would see a lot of the same, but I actually really enjoy being the ultimate expert. So when patients come and see me, you know, I'm going to be the last one to give them the answer, unless they go see one of my colleagues in a different city. I mean, there are not very many people like me who not only treat the voice box, but also the swallowing. So I really like that position. So being an expert is not something that I get tired of. I also really like that, you know, seeing a lot of the same patients just make you very good at handling that patient and becoming very good at kind of anticipating their concerns and the sort of questions they're going to be asking you. Because I split my time between research and seeing patients, I also have the diversity in my week that allows me to not get too burnt out. So that's another nice thing about having a research career, that you can have a little bit more of a balance in life. I mean, so far I haven't been tired. I think each patient is unique. Their presentation might be somewhat similar, but their story is different, and you'll connect with them in very unique ways. And even if the symptoms are the same, it's just always a different story. There's no two story that's similar.
Absolutely, and that's wonderful. I guess we will end on one last question. And if we didn't get to your question, I put in her IG. But as you know, we talked about this a little bit before, but you know, hopefully the pandemic is going to slowly, you know, die down a little bit in the coming months, and we'll be back hopefully shadowing in person and stuff. But until then, do you have any last piece of advice you'd like to leave us with as pre-med students in a very strange time?
Yeah, no, I mean, I think that actually the pandemic, if anything, should give you more energy and passion to join, essential workers and the medical contingent, because clearly, we were the only ones working throughout the pandemic and really being outside. I mean, obviously people were working from home, but we were, making this society still function. So if anything, this pandemic should re-enliven your passion for medicine. I know it's really hard because the firsthand experiences are not available right now, but there are many ways you can continue to learn about the field. So obviously attending this forum, but also, spending time reading. There's some really good books written by physicians. I recommend that you look at some of them, looking at the history of medicine and really understanding how medicine became kind of a profession, I find is also really fascinating. You can look at surgical videos online. And so I would definitely actually find the pandemic as a inspiring moment. I remember reading again The Plague by La Peste de Camus, Albert Camus, the French writer. If you haven't read it, I highly recommend you read this novel, because it's about it's basically a metaphor on the Second World War, but it talks about how a physician is really engaging with the plague in a city in Algeria and trying to save the community. And I found this book very profound in the time of the pandemic. And if you haven't read it, you should really read it.
Thank you. All of them are asking about the name again. They were so excited to read that.
By Camus. Camus is Camus.
Perfect. Yeah, so they're all excited to do that. Thank you so much for those words of inspiration. You are incredible. If you open up the chat right now, everyone's just talking about how incredible you are and how humble and sweet you are as well. It shows through very much. And we appreciate you being here and sharing all of your words of wisdom.
Well, it was my pleasure, and I'm happy to find a way to answer questions in the future as well.
Yeah, absolutely. We'll definitely be in contact with you.
Sounds
And
good.
congratulations.
Thank you so much.
Okay, bye. Thank you.
Bye.
Thank you. Thank you for your time.